So then I'm going to move really quickly to our two speakers, and I'm very excited about it. So we have two of our current postdoctoral fellows in the room who are going to be speaking to us about some of their work. I'll start with May, because she's going first, and then I'll come back up for Kirsty. And just in the interest of time, May 10, this is you're in your second year? Is that right? Okay. So May's working very closely with Reuben Robbins as her scientific mentor. I'm her career mentor. She graduated from University of Houston with a doctorate in developmental psychology. She carried out her dissertation research in rural Zambia as part of an NIH-funded project tracking the growth and development of orphans and vulnerable children affected by HIV. And her areas of interest include cultural psychology and the developmental outcomes of HIV-affected children and adolescents. For those of us who've had the privilege of listening to May, she's very passionate about her work with children in rural Zambia. She's going to continue in that direction, whose growth and progress are being affected by HIV and AIDS, and we're going to hear about that today. She's received several awards in graduate school and HIV Center pilot study. She has a lot of publications, and including, I think, like 19 first author ones before she came to us. So May has a little bit of a longer industrious career. I'm not aging her, I promise. And it's been a pleasure to work with her. And so I'm going to let you come and go.
I haven't done anything yet. All right. Good morning, everyone. Actually, I don't see my notes on this screen. Sorry. I'm just used to seeing them. That's all. Hi, everyone online. Thank you for coming. So, am I not going to see them?
If we leave this, we're not going to be able to see your slides.
All right.
Use your laptop.
Computer. There is room for it, because you don't need the.
Sure. I guess I will.
I was having multiple devices here too, so let's move this. We have this.
Oh, okay.
All right.
And I'm going then, but I need to advance those slides. Yeah, those slides.
Yes. Is that going to confuse?
Yeah.
You can use the clicker. Oh, could she sit there and do it?
No, she's not on Wi-Fi, so you're not going to.
You'll have to do both. Well, I can do it for you. You can sit there. I'll advance it. You just tell me when.
Yeah.
You all comfortable for you. I'll advance for you, so you don't have to think about both. You just tell me. You want to do that? Put speed there so people see you.
Well, it's going to be.
No, only because I've done this before.
Yeah. Well, my notes are my little security
Yeah,
blanket.
that's fine. You just tell me when and I'll. Okay.
I'm a mover, but okay. Oh. That's okay. All right. Everybody, thank you so much for your patience. I'm going to get started so that Kirsty has time also. We definitely want to give a chance for her. Thank you very much for coming. Claude, thank you so much for that very gracious and kind introduction. Let me start out. Today's talk is going to take you on a journey along my career trajectory from my start as a research assistant to my developing K award proposal. Sorry, I can't, it's very hard for me to like say when to. Actually, if
You can
I'll do this, maybe.
Okay.
Yes, thank you so much, Claude. I'm going to start out today by talking about child development and culture, which form the foundation of my thinking about HIV and its effects on children. I'm going to share some of the work that I was involved in early in my research career, and then some more recent work with kids affected by HIV in Zambia. And then I'll talk about some of the current work that I'm doing now with Reuben's group which are leading to my KO1 award, which will address interventions to improve neurocognitive impairment, to address neurocognitive impairment in children. Okay, so first I'll talk a little bit about me. As Claude said, I'm a second year T32 fellow. My scientific mentor is Reuben Robbins. My, my career mentor is Claude Mellons. And heartfelt thanks to them, first of all, and to my fellow fellows for all the support in this program. My aim here is to become an independent researcher focusing on the cultural factors that affect children's development, with the goal of devising and implementing culturally consistent interventions that support children affected by HIV. As Claude said, I earned my doctorate in developmental psychology from the Developmental Cognitive Behavioral Neuroscience program at the University of Houston. I received my master's in cognition and learning from Teachers College here at Columbia. My thesis there was on the development of mathematical thinking in children under Dr. Hope Ginsburg. And as she's noted, I have a very strong interest in cultural psychology, which I'll talk more about. I'll share also that I did not come from an HIV-focused lab. That wasn't part of my training at all. I joined this program specifically because I wanted to learn how to bring my background in child development and my interest in culture to the problems and challenges faced by children affected by HIV. So I want to start out with a quote that's by Sarah Harkness, an anthropologist whose understanding of child development in understudied contexts has really affected my thinking. She wrote, "Understanding culture is essential for understanding child development, and thus for designing and evaluating interventions to improve children's physical and mental," and I added cognitive health. So what do we mean by culture? What does it mean to think about culture? Sarah Harkness said that children develop in environments structured by culture. So I'm going to talk a little bit about what that might mean in terms of children's growth and development. So here's some key defining qualities of culture, which we have to remember first and foremost is made by humans, and by humans specifically as a group. So culture is shared. It's something that a group of people engage in together, to work together, to cooperate, and to foster that feeling of inclusion and belonging that we all need in order to function in society. Culture organizes meanings and actions. It determines how we understand and interpret the world and what's happening around us. It also tells us how we might respond to the things that are happening. A very simple example would simply be rituals of politeness, how you greet people, how you recognize people, how you expect to be greeted back. Those kinds of very simple things that help structure our society and our social relationships. Cultural beliefs exist in or are manifested in a variety of forms, including laws, formal laws, but also rituals that we engage in, also just habits that we have every day, or what become part of our everyday lives. Culture is external, so we can see it in things around us and in people around us, but it is also internal. It's something that we internalize and becomes part of our identity. And finally, culture is resilient to change. And though we have to recognize that culture is changing all the time for various reasons, if we just look around and see what COVID has done to culture now, but we also know, I think, as we work with people around us, that some things about culture, some beliefs, some values, some behaviors are very hard to change, even though all logic and all reason would say that this is what we should do. So in order to understand that better, I like to think about how culture is formed in the brain. This happens through really, as we experience from day one life, we begin to make these connections in the brain. So culture shapes this functional connectivity and the networks as we learn how to operate in our society. And this involves facial and voice recognition very early on, how we learn language, from day one, listening and then speaking, and then all the other cognitive skills we need to function in our environment. So although genetics determines the order in which these kinds of connections come online and are made and are developed, the early experiences that we have really determine the strength of these connections. But as we know, many things can disrupt this particular process. And one of those things is HIV. Despite the availability of, despite the availability of just square.
Click on that so it goes out so people can see your slide.
Despite the availability of antiretroviral treatment that's highly effective, we still have pediatric HIV. There are 1.5 million children still living with HIV today, most of whom live in sub-Saharan Africa. In 2022, 5 out of 6 pediatric infections occurred in sub-Saharan Africa. So this is still a problem that we need to be thinking about. HIV can enter the brain within days of infection. Untreated, it can cause severe structural and functional damage. And so children with perinatally acquired HIV are at high risk for neurocognitive impairment. So I'm bringing these two things together, culture and HIV, because they're what I feel like thinking about. I need to bring them together as I think about interventions, because as we look at problems and we look for opportunities for intervention, I've found that it's important, and what I want to do is look for what is already there, wherever this problem is, what is there already, both internally, in terms of internal and external culture, and particularly cultural strengths, things that are already well established and strong in the communities where I'm working. Okay, so now I'm going to go back to early work that I started as a research assistant in a lab at Yale University. I was able to become engaged in 2 large R01 studies based in rural Zambia, and that's where I began to ask questions about culture and the factors that might be shaping children's cognitive and academic development in this context. These are the 2 studies that I'm referring to, and I'll talk about them individually a little bit more. The first one was an large-scale epidemiological study looking at specific reading disability in rural Zambian children in southern province Zambia. I won't go over the details at this time, as you can see them on the screen, but I'll simply say this was my very first time to travel to Africa. This was the first time I spent weeks and then eventually months in this setting, and I really became enthralled with trying to understand how the environment shapes people's beliefs and behaviors, and why those were different from the ones that I had coming there. I did publish a bunch of papers with co-authors on those topics: cultural factors affecting cognition, academic performance, language, valued roles for children, and formal education. But today I want to talk about, specifically about a different study that I initiated because I wanted to understand how informal activities like chores might affect children's academic learning. So in this study, we looked at we worked with data from children in grades 2 through 6 who had been randomly selected in a school setting. We had a matching sample of out-of-school children for a total of about 1,500 kids. They were given a math assessment. We also got from them a chore score, which was how many out of 5 complex chores they carried out on a daily basis. And we also had a school attendance indicator, which was actual years of schooling over expected years of schooling. We carried out sets of multiple linear regressions separately for boys and girls to understand the relationship between performance in math on certain domains of math, and the relationship with chores, age, and the chore schooling interaction. Oh, sorry, it's a little blurry for me, but I guess not for you. The our results here are in this very we generated a number of these. These are simple slopes from the results, and I'll explain as I can. This is from the girls, and looks at their performance on early math. You can see the math score is on the left-hand side on the y-axis, and across the bottom is their school attendance in ratio. So the 0.1 there on the left would mean they had 1 year of schooling when they should have had 10, right? So, and then the lines indicate those children who had different levels of chores. So this red line that I'm highlighting here, those are the kids who indicated having 4 chores that they normally carried out. And you can see there on the left-hand side, when their attendance is low, when their school attendance is low, then their math score is higher than other kids who have lower numbers of chores. Still below average, but that's they're doing better. They know more than those kids who have fewer chores. But as you move along that line for school attendance, when you get to the right-hand side, which is where the ratio is 1, where they're in the grade that they're supposed to be in, those chores actually are putting them at the bottom of the performance. And that's the interaction effect here that we're seeing between chores and school attendance. So when you have more chores and less schooling, you might be gaining something from those chores in terms of early math knowledge and skills. But if you are going to school full time all the time and you have 4 chores at home, then you're doing worse, right? And we can see that the opposite is true there, where the kids on the blue line have 0 chores and they're doing worse at first, but get over there to where they're in school full time, they're doing better. So you can see here, there's effects of both chores and schooling on math learning, and they are interact such that when you have less schooling, chores can be an important source of knowledge. So for me, that was a very important finding, because then I could say, yes, we can see how math learning, and which starts very early in life, can be developed through informal activities. And the most common example of that usually cited is Brazilian children selling food on the streets of Recife, where they learn a lot of math skills even when they're not in school. But the other important thing that this indicates now is that when you want to intervene on math learning, for example, what would you say? You would say, well, we could do 2 things. We could look at their chores, how many chores they're doing, and we could look at their schooling, and we could look at how they interact. So if they're not able to go to school, having more chores or certain kinds of chores might really help their math learning. But if they're able to go to school full time, it might be better if they have less. So that gives us 2 already existing and embedded activities that these kids already do that might affect their academic learning in the area of mathematics. So there was a similar chart like this for boys, and for girls, this effect was seen in 3 other math topics: concrete math, which had a lot of pictures of common items, everyday items, abstract math, which was just numerical only, and simple operations like addition, subtraction with single-digit numbers. So there was more effect for girls than boys for various reasons that I won't get into right here. The second R01 that I worked under as a grad student is a community-based evaluation of interventions for orphans and vulnerable children affected by HIV. This was my introduction to working with HIV-affected children. I had never done that before, and it was through working in this setting for 6 years and visiting and educating myself about HIV that I found it to be such a compelling problem. And it's, that's why I applied for this program, in fact. So in this project, we screened 4,702 households in 3 waves. Those are the 3 colors on that map within a 20-kilometer radius of this Macha Mission hospital there. And we were screening for children affected by HIV. These are children who either have HIV, children who have been orphaned by HIV, or who had an HIV-positive caregiver. We enrolled 607 households. You can see those in the map below, scattered around in the various areas there. And that comprised 1,194 HIV OBCs. And we followed their cognitive, academic, and physical growth over time, assessing them at 3 time points about 1 year apart. We also documented any free services that they were receiving. So the study that I want to highlight from that work is our comparative look at the comparison between HIV positive and HIV negative, but exposed unaffected kids. So there were 82 HIV positive kids, 7 to 17 years old, and a little over 1,000 of the exposed unaffected kids. We compared their performance on cognitive and academic assessments, controlling for age, BMI, years in school, and SES. And we carried out a multivariate analysis of covariance on their performance. Yep. As you can see here, it's not really unexpected that the HIV positive kids in the red bars are doing significantly worse than their HIV negative counterparts on just about everything except RC1 and RC2, which were our reading comprehension subtests, which I think kids just struggled with reading overall in schools. The RAN on the left is a time test, so the higher time point indicates worse performance. You can see here that they did differ significantly in the p-values there. Let's see, I guess you can't see, you can't see my little pointer, but yeah, everything is significant there except for the RC1 and RC2. But the important thing here is that this partial eta square, the variance explained by their HIV status in their performance, was very low, in fact. So we looked at these covariates, and we could see that BMI had a little effect on these, SES had a little effect on these, but the major source of explaining the variance in these scores was age to some extent, but very prominently years in school had a very much higher effect. Wouldn't call it, I don't know if I'd call it a high effect, but had a much higher effect on their performance across these subtests than their HIV status. So suggesting again the importance of schooling for cognitive development in HIV positive and you know, the children in the sample. So that just leads us again to be thinking about what, how can we think about schooling as a potential source, place to intervene. But that brings me to the work I'm doing today with Reuben Robbins' group and his team, who have recently collected data in Uganda from youth with perinatally acquired HIV, and this work is leading directly to AK. So the study that Reuben is leading is called Enrich, Enhancing Research for Inflammation and Cognitive Health in Perinatally Acquired HIV. And in the study, they're investigating how immune activation and inflammation due to a number of environmental stressors might contribute to neurocognitive impairment in youth with perinatally acquired HIV. The sample is 100 youth ages 11 to 18, 50% of whom are HIV positive and virally suppressed. 50% are HIV negative. They were administered a set of behavioral health assessments, a neurocognitive assessment battery, and socio-demographic and medical data were also collected. Sorry, my slides reformatted on this new computer, so you're missing a very important part, but the analysis and results I'd like to share is from a k-means clustering exercise that was applied to the participants based on their performance on the 12 subtests of NeuroScreen, so the cognitive tests. This is a very busy slide, so I'm sorry, but we're going to look at the graph first on the right, where you can see the subtests of NeuroScreen are along the bottom, and the mean scores along the left. And you can see that 3 out of this K-means clustering exercise, 3 main groups emerged. A top one, the red, which is doing fairly well. They look pretty normal up there. Then you've got a kind of mixed group in the blue in the middle. And then you have a fairly low performing group across many subtests down at the bottom in the green. And the important part for me out of this is that there are HIV positive kids in all of these groups. You can see the numbers on the side. I've put them on the graph to just make it a little easier for you. But in the red group, which has 50 kids, there are 19 kids in there who are HIV positive. And also in the middle group, where there are 18 kids out of 31 who are HIV positive, the lower group is actually all HIV positive, all 11 of them. So we wanted to look at how these groups might be different, what might be distinguishing them, looking at these factors in the table. But we found that these groups were not differing by age significantly. They did not differ by gender significantly. They did not differ by household monthly income significantly. Where they did differ was in their grade and this variable actual minus expected grade. So we calculated based on the expected school attendance of kids starting school at the age of 6. So if you start in school when you're 6, you're in 1st grade. We just did a simple math exercise to calculate where they should be if they start school at 6 and where they are actually, whatever the grade that was reported at the age they were at. So you could see here that there is a difference between the actual and expected grade of 3 years in group 3 and of 2.25 years or so in group 1, and this was significantly different. I also included at the bottom some HIV-related variables, just in case some of you are interested. These are actually pulled out of an HIV-only cluster analysis, but you can see here that age at ARB did not distinguish those 3 groups that emerged. And although their nadir CD4 did differ in 2 groups, they're actually doing very well. They're doing just fine health-wise. So we wanted to go back to this grade and expected grade difference variable to see how that might be playing out with kids with and without HIV. So we went back to this, looking at the HIV positive and HIV negative kids comparison. And you can see here that when you look at this grade lag that's being experienced by some of the kids, well, you can see that almost all of them are, most of them are. The 0, the red line there indicates, so those are the kids, that's where you are if you are at your expected grade. There's no difference between your actual and expected grade. But to the left of that, you can see that most kids, HIV positive and HIV negative, they are delayed from that sort of standard. But the HIV negative kids have an average delay of minus 1.89 years, and the HIV positive kids have a delay of minus 3.25 years. And you can see there the red tail at the end. There's a few kids there who actually have quite a bit of delay. And so there's a lot more I could say about this data, so I'm not really doing it justice, but I'm going to sort of move on from here as we see again that schooling can be playing a role here in how HIV positive kids are not developing neurocognitively for reasons above and beyond their infection. And this poses this question again of, well, how can schooling how can we capitalize on schooling to intervene on these kids' neurocognitive development? And what would a school intervention look like? That's a kind of a big question. I'll move on really quickly to my K, where I try to tackle that because we know that going to school isn't the reason that you're developing well. It's actually the learning part that happens. I am proposing in my K to increase executive functioning in children with perinatally acquired HIV using a math-based educational intervention. And so I'm going back to my math roots in some sense. And going to work with that to develop an intervention. Why executive functioning? Well, let me start actually with the culture piece. What I love about this approach is that I think that it's highly feasible, it's highly acceptable. Let's go there. It's very familiar. School is an institution that everyone is familiar with, that is not going to be strange to anyone, even mathematics learning. It's nothing new really, but it's going to be more of that, something that's not new. So culturally, I feel like it's a very good fit. Cognitively, we're going to focus on executive functioning because that is one of the areas of cognition that HIV positive kids are commonly identified as lagging in. And that also happens to be very closely related to mathematics knowledge and mathematics skills. So as you build skills in math, you tend to be building your skills in your executive functioning skills and abilities. And so these two things go hand in hand and develop together, and therefore math learning seemed to be a very good way to get it increasing cognitive skills in a familiar and acceptable way. The other thing about math is that I feel like there's no ceiling for math. It's an infinite intervention. And so you can address children wherever they are and build their skills from wherever they're starting from. And we're going to start with kids where we know there's a lot of brain plasticity. So hopefully to make good lasting changes. All right, I have like 30 seconds to say, this is my K proposal, which is really under development, but I'll conduct formative qualitative research to understand the social and cultural context of early childhood education and executive function development in the study region using interviews, focus groups, and observation, where I'll also get my training, I hope. I will create a mathematics intervention by selecting and adapting activities from learning trajectories, which is a wonderful set of math instructional activities from a very well-known math researcher here in the US. I'll work with both math experts here and in Zambia, and then implement the 8-month pilot trial to evaluate its feasibility and acceptability. So more on that later, I hope. For now, I'll just say thank you very much for your attention today. Questions, I guess we'll handle after Kirsty goes. Thanks to everyone here at home in Uganda and Zambia. I'm gonna try to navigate out here.
No, that's all.
Do I stop share?
Yes.
I'm going to go to the folder.
So thank you, everybody. May, that was really, no, super interesting. And having seen a few versions of this, it's a wonderful story and helping us on your journey of where you got to. Everybody, we're going to do questions at the end so that Kirsty has a chance to speak. I apologize in advance for the technological issues that just got us started a little late. So please write your questions down if you have questions for May. But I really want to thank you. I'm not going to say much more, just so that, forgot my name. Wait, Kirsty, I have to you. Can I introduce her while you're doing that? Okay, so I'm going to introduce Kirsty while we're getting her slides. Kirsty is also a fabulous postdoc along with May in our program. I've had the pleasure to actually get to know her a little bit. I meant to say this about both May and Kirsty, and I think I say this a lot, but I'm always really I just want to acknowledge it's really impressive work that the fellows bring to us. And for some of our fellows, they're also raising children at the same time. Those of you online can't see Kirsty at the moment. No, I'm not, I'm thinking about what you said, May, and I think that it often brings important work to your parenting, and it brings important parenting skills to your work, and it humbles us all. So I just wanted to say that. So Kirsty is also in our fellowship, and her mentors are here, and John Santelli and Phil Kroniski. I don't know if Susie's online, but I want to acknowledge Susie. Kirsty comes to us from Hopkins and Georgetown undergrad, is that right? She also, I'm going to be quick, she has also numerous honors and awards while in undergraduate and graduate school. She's a PI of an F31 grant, which means you're getting a grant before you even get here for your dissertation, which is really impressive. You also have a lot of publications, and your work focuses, now I have to switch devices, in this whole, Kirsty's work focuses on the influence of social connections and environments on young people ages 10 to 24 in the context of HIV. She's particularly interested in collaborating with young people to design and evaluate acceptable, suitable, and feasible interventions that engage families to support HIV prevention, testing, and treatment among young people. You have a growing interest, I know, also in mental health. So that's part of some of what we've talked about besides our own. And it's, this is all really, really challenging. So with that, I'm going to turn it over to
you. Good morning. Thank you, Claude, for those kind words, and to May for starting off our rounds this morning. So I'm excited to continue our discussion set in Zambia by sharing some of my dissertation research titled Examining Family and Household Factors Related to HIV Self-Management Among Adolescents and Young Adults Living with HIV in Ndola, Zambia. So for those of you who don't know me, I joined the HIV Center in the past year. My scientific mentor is Phil Kroniski, and my career mentor is Susie Hoffman. I also have the opportunity to work with John Santelli. Previously, as Claude mentioned, I was at Johns Hopkins, and throughout my education and career, the research areas that I've come to focus on have really been centered around HIV and sexual and reproductive health, particularly among adolescents and young adults. I'm interested in supporting this group's health and well-being through creating enabling environments, chiefly through engaging the family and household level. And the research that I'm about to present very much reflects these research areas and is a good example of the portfolio of work that I seek to expand. So I'm going to first set the stage for these studies with some of the background and theory that oriented this work. So as many of you know, adolescents and young adults, or AYA 15 to 24 living with HIV, are of note in part because they tend to have poor ART adherence and as a result, lower rates of HIV viral load suppression than their adult counterparts. And as a result, HIV self-management is essential to facilitate the health and well-being of youth in real time, as well as to support them to enjoy the same opportunities and successes as their peers who are not living with HIV. So as a reminder, HIV self-management entails the processes and behaviors necessary to manage and thrive with this chronic condition on a daily basis, as reflected in this image. Notably underlying self-management are individual and social influences that can positively or negatively impact self-management practices. So for youth to be able to successfully transition to self-management, they require support and partnership, including from their caregivers and family members. So this brings us to the need to engage the family and household in supporting youth HIV self-management in the context of youth living with HIV. The family and household is particularly influential in shaping their health and behavior. Notably in sub-Saharan Africa, members of youth's family and household are often the only people aside from their healthcare providers who know their status, and therefore they're well positioned to provide HIV care management support. There's a growing consensus on the need to involve families and households in supporting youth's transition to HIV self-management in sub-Saharan Africa, including in Zambia. However, to date, there's been limited research and intervention to this end, though fortunately, the chronic illness literature is replete in this area and provides useful insights on how family and household factors relate and lead to youth self-management. I could talk extensively on this. I don't have time to today, so I'm going to let the pediatric self-management framework be a good exemplar of this. And that's the theory that oriented this work. So I drew upon this to shape my research questions, my hypotheses, as well as guide my analyses. This framework offers theoretical considerations for successful self-management of chronic illness among a pediatric population. It's, as you can see, it's structured by the socioecological domains representing the healthcare system, community, family, and individual. And across these domains, this framework considers how contextual influences, self-management processes, and self-management behaviors interact to shape adherence, frequency, and health-related outcomes. Further use health-related outcomes may also feed back to inform these influences and processes and behaviors. I value this theory as it's an actionable tool to support programmatic research and design focused on self-management among youth. Specifically, this framework offers valuable insights into the types of considerations and inquiry necessary to better understand how family and household level factors relate to and influence youth self-management. So I want to take a moment. I'm not going to go through all of this, don't worry. I just want to take a moment to define one key component of this framework that's central to the analyses I'll be presenting. So modifiable influences highlighted in pink. These are contextual factors that may be modified through readily modified through intervention. And at the family level, some examples of these include family health beliefs and perceptions or family functioning. My overall goal for this dissertation work was to better understand how family and household factors relate to and influence youth HIV self-management. So I accomplished in part through the first analysis in which I qualitatively explored caregivers' experiences with youth who are transitioning to self-management. As understanding caregiver experiences are important given that they're situated within the youth's family and household environments. Finally, I built upon the insights from the first analysis through a follow-up study where I qualitatively explored modifiable family and household level influences on youth self-management. This dissertation research was situated in the context of Project Yes, Youth Engaging for Success, which was a study that was set in Ndola, Zambia, and ran from 2017 to 2019. So Project Yes served to increase the viral suppression and decrease internalized HIV-related stigma among youth living with HIV. There's lots I could say, so I'm just going to give some context of what the intervention was and the participants. So this included a clinic-based youth peer mentoring intervention and included monthly one-on-one and group meetings with a youth peer mentor, which took place over a 6-month period. There's also a caregiver component in which caregivers, if invited by their youth, had the opportunity to participate in an orientation and up to 3 caregiver group meetings. And these meetings focused on improving caregivers' capacity to support their youth living with HIV throughout this transition to self-management. Youth participants were living with HIV, aware of their HIV status, had been on ART for at least 6 months, were attending one of the 4 participating clinics, and were available and interested to participate in the study for the next 12 to 18 months. And caregivers were eligible to participate in the intervention and select data collection activities if invited by their youth. Okay, so now that we have the context for this work, let's turn to the methods and result of the caregiver analysis, which sought to qualitatively understand caregiver experiences with youth who are transitioning to self-management. So I utilized caregiver in-depth interview data that was collected during the Project Yes study. A thematic analysis was employed to discern patterns in data. I started with an inductive coding approach to discern codes that emerged from the data and subsequently expanded the code book to include deductive codes based on the pediatric self-management framework, as well as key domains within the interview guides. Memoing matrices and thematic maps were employed to identify, define, and reevaluate emerging themes and subthemes. So from this analysis, 3 key themes emerged. First, caregivers' commitment to meet the needs of youth living with HIV. Nearly all respondents conveyed a commitment to their youth's health and well-being, as well as a willingness to meet their needs to this end. This was demonstrated in part through discussions of motivation. Several caregivers shared how their desire to support the youth's health and well-being motivated their own actions and decisions, particularly their motivation to participate in Project Yes. Some of the youth were motivated to, some of them were motivated to join Project Yes to improve their capacity as a caregiver, while others wanted to show their youth that they cared about them. As captured in this quote from one mother, "I wanted to support her, for her to see that she is not alone. I didn't want to miss." Commitment to the youth's health and well-being was also expressed by several caregivers in the context of financial considerations and obstacles. These caregivers valued and prioritized opportunities for education and support that benefited the health and well-being of their youth, such as what was offered through Project Yes. Second, most caregivers shared considerations for communicating with their youth, many of which are captured in this quote from one mother. Those who discuss with the children should not be harsh with them. As parents, if you also make them upset, you'll not solve anything. So you need to observe that today he's in a bad mood, so you'll start to be gentle with them. And when they normalize, then you can tell them what needs to be told. I feel like a lot of parents are relating to this right now. When they so the majority of these caregivers stress the importance of communicating in a manner that was gentle and supportive for the youth, or on the other hand, avoiding harsh interactions. And being gentle and supportive was often discussed by these caregivers as beneficially facilitating the youth's health and well-being in the context of HIV. While being harsh was described as counterproductive to this end. Several caregivers also described how they offer encouragement to their youth regarding living with HIV. Some noted the importance of offering reassurance to the youth, while some would speak frankly about the consequences of not taking medication consistently on time, as well as reminding them of the benefits of maintaining adherence. Finally, some caregivers emphasized the value of knowing how to deal with their youth or otherwise possessing an understanding of their youth. Such knowledge and understanding were described as invaluable to gauge the youth's mood or needs, as well as to interact with them in a manner that would facilitate productive discussion. Regarding the third and final theme, caregivers offered insights on building their youth's capacity to self-manage, as well as their mutual confidence in this capacity. Most caregivers stress the importance of their youth being able to take care of themselves, which was typically described in terms of acceptance of their HIV status, adherence, clinic attendance, and sexual behavior. Several caregivers also shared their specific perspectives on and experiences with supporting youth and to take greater ownership over their HIV self-management. These caregivers would give their youth space to do so with specific aspects of their HIV care management, all while providing support in the form of paying attention to the youth's health behaviors to this end. So some would do so specifically by holding on to their youth's medication or their appointment card and waiting for the youth to come to them for these items rather than proactively offering it themselves. This is conveyed by one mother who noted, "I support him because I keep his medication in our bedroom. He takes it in the morning and in the evening. So what I want is that even if I'm sleeping or in the morning when he's leaving, I like to see that he's taking his medication. I don't remind him, he just comes himself. He knocks on the door, he enters and takes his medication." By being aware of but not actively managing these aspects of their youth's HIV care, some of the caregivers suggested that they'd have the opportunity to intervene, so remind them to take their medication or that they need to go for their appointment. So the youth, in the event that the youth was failing to do so themselves. But in practice, most caregivers indicated that they observed that their youth was actually successful to this end, with attending their appointments or taking their medication, which in turn is suggesting building mutual confidence. So considering the key takeaways of these results, caregivers' commitment is important to understand in part as a potential barrier to youth transitioning to HIV self-management, as caregivers may struggle with shifting from a primary to a more secondary caregiver management role. This commitment is also a notable facilitator, as caregivers indicated how they would take action to support their youth's HIV care. This finding speaks to the ways that caregivers are invaluable resources, which should be supported and engaged to support youth's health and well-being. Additionally, the importance of positive and constructive communication between caregivers and youth was upheld in this analysis. Interventions to support youth HIV self-management should include discussions and role-playing to strengthen caregivers' communication skills to this end. And finally, the gradual and engaged approach, which I've termed scaffolding based on the literature, should similarly be encouraged among caregivers whose youth will be transitioning to HIV self-management. This approach allows youth to have opportunities to develop, hone, and gain confidence in their skills with minimal interference from their caregivers, while limiting the potential of negative outcomes such as non-adherence through caregiver oversight. And again, through this approach, caregivers are likewise able to gain confidence in their youth's abilities. Now for the follow-up study that sought to qualitatively explore modifiable family and household level influences on youth self-management. Primary data for the study was collected from young adults and their caregivers. I sampled former Project Yes youth participants who had consented during Project Yes to future contact. Specifically, I used maximum variation sampling based on the responses regarding family connection in the Project Yes baseline survey, but also with consideration to sex and age. Young adult participants were eligible if they were between 18 and 24 years of age, unmarried, and willing to invite a caregiver to participate. Caregiver participants were identified through the enrolled young adult and were eligible if 25 years of age or older. Individual interviews took place remotely due to the COVID-19 pandemic and were conducted by my trained research assistant in the participants' preferred language of English or Bemba. We interviewed a total of 17 youth and 13 caregivers. And a similar analytic approach to the prior analysis was used, as noted on the prior slide. I want to highlight the key difference is the use of episode profiles, which were used to be able to compare and contrast the caregiver youth dyads. Five modifiable influences at the family and household level were salient. Notably, these were all in line with examples offered by the pediatric self-management framework, if any of you were very speedy readers on that extensive slide I presented earlier. So first, family HIV beliefs and perceptions. This was primarily reflected by the presence of HIV-related stigma and discrimination described in the youth's family life. Participants described their experience and views regarding the harms of stigmatizing beliefs on the part of family members, such as inhibiting youth from being open about their status and even leading them to skip or discontinue their medication. Whereas living with a family member in a family environment free of HIV-related stigma was described positively and with appreciation by some of the youth respondents. Such a family environment made these youth respondents feel good and accepted, facilitated constructive and open interactions with family members, and moreover made it easier for the youth to live with their HIV. This modifiable influence is well conveyed by a 19-year-old young woman who shared, "Since I don't have anyone who has avoided or stigmatized me, so why should I not be open with them when I need help with my HIV care as well?" Family involvement was demonstrated by how engaged and concerned family members were in the youth's HIV care management. Many of the youth respondents indicated that their family checking in, as well as being concerned about and engaging in their HIV care management, made them feel cared for or good. This is really conveyed by one 19-year-old young woman who shared, "It feels really nice when my mother reminds me to take my medication, that she really cares for me." On the other hand, a few youth also noted the absence of family involvement and with it, a lack of care for their health and well-being. These experiences predominantly centered around HIV-related stigma discrimination and former caregivers or family members who made the youth feel rejected or alone. Most caregivers demonstrated their ongoing involvement and concern through discussing how they monitor and supervise the youth's HIV self-management. Many caregivers asserted how even following successfully scaffolding and supporting their youth's transition to HIV self-management, they did this to ensure they continued to monitor their youth's clinical review results and self-management behaviors. They did this to ensure that their youth maintained good health and that they could support the youth self-management as needed, recognizing that living with HIV is a never-ending process and that the youth will need this type of support from time to time. As indicated by one older sister, "It's just from time to time that I remind her to go to the clinic or take her medication, because sometimes they get to forget about everything because of maybe being too tired due to academic pressure," which again, I think many of us can relate to in this room. Most caregivers also describe this type of involvement as part of their caregiver role and responsibilities, in line with findings from the prior analysis. These respondents indicated an inability to stop monitoring and showing concern for their youth in this manner. Family relationship quality was reflected in the closeness, intimacy, and care that was felt in these relationships. Something that was really interesting and unexpected in these results was the interplay that was evident between the salient modifiable influences through these influences. So through these interviews, it appeared that influences like family relationship quality and family involvement were constructs that informed and even built on each other. So this is evident by how youth and caregiver respondents would often discuss the quality of relationship with a family member in terms of how the youth felt cared for, which, as noted in the prior slide, often resulted from family involvement. So many youth emphasized how feeling cared for by their family members would motivate their ART adherence and self-management. This sentiment was expressed by one 23-year-old young man who stated, "Me being raised by a family member that cares is the way to learn that I should care about myself, so I still care for myself, even if I'm doing my own thing away from home." Being close with a family member was also related to how comfortable and free a youth was around their family. About half of the youth respondents discussed this comfort in terms of how easily they could do everything they needed to successfully self-manage HIV in their household. Finally, family functioning was evidenced by how youth's HIV care was coordinated among family members, the availability of family support perceived by the youth and caregiver, and the extent to which the youth felt they could communicate with family members about their HIV-related experiences and needs. This is well conveyed by one mother who stated, "I'm sure the way our family works together has had an effect in one way or the other, because when children are growing up, the way your parents or relatives relate, it has an impact on the children. But the way we relate in our family, I'm sure it's had an impact on him, leading to his health improving, because with us, there are no feuds within the family." So putting these results in context, what are the key takeaways? First, the important role of family HIV beliefs and perceptions, involvement, monitoring and supervision, relationship quality and functioning are maintained within the study. Further, the collective findings from our study offer greater depth and understanding on these modifiable influences in the context of youth living with HIV and their caregivers in a sub-Saharan African setting, which is notable as the pediatric self-management framework is more oriented towards non-communicable chronic conditions and in high-income settings. Through these interviews, we learned more about what modifiable influences were salient in the respondents' experiences, as well as their meaning and significance regarding youth HIV self-management. Further, we observed that there's interplay and overlap in these influences that's not evident within the pediatric self-management framework. It was also clear through the experiences of these respondents that these modifiable influences at the family level have implications for more than just self-management support processes and behaviors of family members, as the literature and theory would suggest. Modifiable influences at this level in and of themselves appear to have direct implications for the youth. Youth noted how their perceptions and experiences with these influences would affect their feelings and attitudes, as well as how these influences could facilitate or inhibit their own actions, particularly regarding practicing consistent adherence or seeking support when HIV care was needed. In this regard, these modifiable influences collectively appear to inform the presence of an enabling environment in which youth can successfully self-manage their HIV. All right, so this brings us to our final section, conclusions and next steps. So the findings from this dissertation affirm the importance of the family and household in the context of youth HIV self-management. Through these qualitative assessments, we're reminded of the significant and continual role that the family can play in self-management. In the field, there's often an overemphasis on youth being able to take ownership of their HIV care and be capable of managing it primarily on their own. But self-management isn't meant to be a solo endeavor. Part of self-management is actually being able to cultivate the relationships and get the support you need from family and peer connections. This dissertation addressed gaps in literature and expanded our understanding of how the family and household shape HIV self-management among youth in sub-Saharan Africa and future opportunities to this end. Specifically, we identified modifiable influences at the family and household level that were notable in shaping HIV self-management and outcomes of youth living with HIV. So these findings have important implications for guiding future research and intervention. Some specific recommendations include the use of constructive communication, checking in, and scaffolding in family and household level interventions to support youth living with HIV, as well as deliberately addressing family modifiable influences and interventions of this like. And finally, as we work to successfully engage more members of the family and household level beyond the caregiver, co-developing additional intervention approaches with youth and their families. Which brings me to my next steps. So my dissertation research, again, it reaffirmed the importance of the family and household in the context of experiences of youth living with HIV. And so the next place that I want to go is to expand the intervention offerings to this end. But the question becomes how. So the family and household domain, it's private. There's lots of variable dynamics and structures, et cetera. And particularly when we're thinking about a stigmatized condition like HIV, how do we meaningfully engage the family to improve aspects of youth health and well-being and HIV outcomes, but in a way that's low risk and not introducing harms? So with this in mind, I started thinking about how I could begin to take action on these results in a manner that would be feasible and acceptable to all involved. Which brings me to the K01 grant that I'm developing. You'll hopefully be hearing more on this from me soon. But in short, my goal is to collaborate with Youth in Rakai, Uganda to adapt an intervention that addresses family factors central to PrEP and ART adherence, as well as anxiety and depression. So my first aim, I've got these preliminary aims up on the slide here. In my first aim, my goal is to apply the insights I gained through my dissertation set in urban Zambia to understand the role of family factors among youth in rural Uganda. But I want to expand the scope of this work further by taking a status-neutral approach and understanding factors that are core to adhering to HIV prevention and treatment regimens, as well as the influence on the prevalence and severity of anxiety and depression. And then subsequently, I will hope to apply these insights to co-adapt a family and household intervention with youth and their caregivers, and then pilot and evaluate for feasibility, acceptability, as well as impact. So I'm seeking to expand my training to better position me to grow this research portfolio, specifically by building my skill set pertaining to youth engagement, community-based participatory research, intervention adaptation, implementation science, Also expanding my scope to incorporate a greater focus on mental health in my work, recognizing that how central it can be to use experience in the context of HIV. I didn't have time to get into it today, but that was another growth point throughout my dissertation. So yeah, hopefully more on that soon. And with that, just want to briefly acknowledge the mentors I had at Hopkins, the project guest study team, my research assistant, and my study participants who made this work possible. And then funding from the NIH, Johns Hopkins CFAR, Center for Qualitative Studies in Health and Medicine, Georgina Bookbinder Memorial Fund in International Health, and then PEPFAR, who made the project study possible. Thank you.